Thank you for joining today's webinar hosted by Vyaire. Today's speaker is Cheifetz. He is Professor of Pediatrics, Medical Director from Rainbow's Babies and Children's Hospital. Please note the disclaimers on the page. Take just a few moments. Note that all Vyaire products are property or trademark of Vyaire, that as an attendee, you need to read through these disclaimers. The presentation may contain case studies or clinical reports based on our presenter's clinical experience. And material presented today is not for promotional use. So again, welcome to today's presentation. And at this time, I am going to turn it over to our presenter.
Great, thank you, Beth. Let me share my screen. And hello, everyone. Thank you for joining today from across the US and I believe across various countries of the world. It's my pleasure to be here on behalf of Vyaire to discuss non-invasive respiratory strategies in pediatrics. At the end, we'll make sure that there will be some time for a question and answer discussion. So I'm going to start off with a case that many of you will have seen in some concept. This is a 12-year-old boy who's previously healthy and presents to a PICU with a one-day history of worsening respiratory distress. PCR shows influenza A, and the patient is presumed to have a bacterial superinfection based on clinical presentation, including a fever of 39.5. He's tachypnic, breathing in the 50s. Saturations are 88% on a non-rebreather mask upon his arrival to the ICU from the emergency department. He has moderate increased work of breathing on your assessment. Patient is well perfused with good capillary refill, somewhat tachycardic with a heart rate in the 140s, and his neurological status is normal, except for he's somewhat sleepy after being ill for the last couple of days. So the question that I would ask for discussion, and we can discuss this at the end of the presentation, would you start by supporting this patient with high-flow nasal cannula, non-invasive ventilation, or do you believe his severity of illness and presumed trajectory might warrant intubation without a trial of a non-invasive respiratory strategy? So learning objectives for the next 45 to 50 minutes or so will be to review approaches to non-invasive respiratory support for pediatrics and to evaluate the clinical evidence to support their use. We'll discuss indications and contraindications for non-invasive respiratory support for acute conditions. We'll explore how best to select the optimal approach of non-invasive respiratory support for each type of patient. And we'll review when to escalate to intubation, including, of course, invasive mechanical ventilation. We'll also, at the end, consider some challenges to non-invasive respiratory support in pediatrics. To start, this publication from Vyaire in the Respiratory Care 2017 overviews the various clinical scenarios and clinical conditions for which non-invasive respiratory strategies may be employed, both in infants as well as children. And as you see on this slide, almost everything you can think of is listed here. And they all could be supported depending on the patient's specific condition with CPAP, non-invasive ventilation, and/or high-flow nasal cannula. In many ways, this slide could be replaced with a simple word that says anything. So almost any condition nowadays is a potential approach or potential scenario in which one could try a non-invasive respiratory support. Doesn't mean in each situation it's the right thing to do, but in many situations across the globe, these are entities that are being supported non-invasively. So for this presentation, I'll start off just with a few slides on a historical perspective where non-invasive respiratory strategies got their start. We'll spend a fair amount of time talking about pediatric ARDS. We'll then focus a little more briefly on asthma, post-extubation readiness, respiratory distress, and intra-hospital transports. And then in the last section, which will be a good portion of the presentation, we'll talk about outcome predictors, challenges, risks, and benefits. So to start, this is one of the first well-accepted, well-published publications on non-invasive ventilation from Antonelli in the New England Journal in 1998. This publication gained a lot of attention for early use of non-invasive ventilation by comparing two groups, albeit by current standards of non-invasive ventilation in the adult world, small groups of subjects, each having 32 patients. In this publication, in this study, what we see here is that the patients who were ventilated non-invasively had a lower complication rate than those patients who were ventilated conventionally with intubation. In addition to the rate, we also look at the number of complications per patient, were also notably lower in the non-invasive ventilation group. If we now come down to the lower half of the slide and we look at the differences in complications, what we see here are those patients who develop sepsis and/or pneumonia were lower in the non-invasive ventilation group. Conclusion from this study is that non-invasive ventilation was a reasonable approach for those adults with hypoxic respiratory failure, and it helped to reduce infectious complications associated with intubation and invasive ventilation. Subsequently, Keenan and colleagues in critical care medicine in 2004 performed a really excellent meta-analysis looking at the various non-invasive publications to date, all in the adult population, showing that non-invasive ventilation led to a reduction in intubation rate, ICU length of stay, and ICU mortality. A year later, Dean Hess and colleagues in respiratory care published their meta-analysis looking at infectious benefit or a reduction of infectious complications benefiting non-invasive ventilation, again in adult patients. So with this, the world of non-invasive ventilation really took off. What about high-flow nasal cannula? It really gained national, international attention with this publication in the New England Journal in 2015, high-flow oxygen through nasal cannula in acute hypoxemic respiratory failure. This study showed the benefits or presumed benefits of high-flow nasal cannula. In adults with PF ratios less than 200, it was shown that high-flow nasal cannula, as demonstrated in red, led to a lower rate of intubation as compared to standard oxygen therapy or non-invasive ventilation. Similarly, high-flow nasal cannula, high-flow oxygen led to a higher survival in these adults with acute respiratory failure than standard oxygen therapy or non-invasive ventilation, putting high-flow nasal cannula as a standard approach for at least adults with hypoxic respiratory failure. Since this point, the debate between high-flow nasal cannula and non-invasive ventilation continues, and I apologize if the background overhead is coming through. With this, the ongoing debate occurs, and in pediatrics, it's important to mention that we don't have any such data. So with this, we'll move on to discussing clinical applications and starting with pediatric ARDS. First point I want to mention here for pediatric ARDS is the new PALIC 2 definition. And for those who are not aware of PALIC, is the Pediatric Acute Lung Injury Consensus Conference second version, which was completed in 2022 and published in Pediatric Critical Care Medicine in 2023. With this new definition, what we see here is a definition for non-invasive parts, and those patients who are supported with non-invasive ventilation using an nasal oral mask or a full face mask with a PF ratio less than 300 or an SF ratio less than 250 is consistent with the definition of PARDS. Non-invasive PARDS is then broken down into mild, moderate for those patients who have PF ratios between 100 and 250, or an SF ratio between 150 and 250, and severe PARDS for those with a PF ratio less than 100 or an SF ratio less than 150. Furthermore, the PELIC-2 group looked at diagnosing not only PARDS, but also those patients at risk for the development of PARDS and those patients that have possible PARDS. So for possible PARDS, it is defined as a patient who is on nasal continuous positive airway pressure or continuous positive airway pressure or BiPAP, or at any settings, or high flow nasal cannula greater than 1.5 liters per kilogram per minute, or an absolute flow greater than 30 liters per minute, with a PF ratio again below 300 or an SF less than 250. Those patients deemed to be at risk for the development of PARDS includes those patients with any type of oxygen supplementation to maintain a saturation greater than 88%, but not meeting the definition for PARDS or possible PARDS. We now move on to the inner work of the PELIC-2 group and look at the subgroup that looked at and researched and did a complete meta-analysis of non-invasive respiratory support for pediatric ARDS. The conclusions of this group, before we get into the details, is that non-invasive ventilation is a widely used modality for the treatment of respiratory failure in children and may be beneficial in a subset of patients with PARDS. However, there needs to be close monitoring for worsening disease and non-invasive ventilation failure. The first recommendation from this group is that they suggest, a little weaker than recommending, suggest that in patients with possible PARDS or at risk for PARDS on conventional oxygen therapy or high-flow nasal cannula who are showing signs of worsening respiratory failure, a time-limited trial of non-invasive ventilation, whether that be CPAP or BiPAP, should be used if there's no clear indication for intubation. It's important to note that this was based on a very low certainty of evidence, given the void of definitive evidence in the pediatric population, and 88% of the experts involved with the PELIC-2 consensus conference agreed. If we look at the evidence supporting that recommendation, what we see here is a series of publications going back to the early 2000s, 2006 being the earliest in this series, and through multiple different approaches of these studies, but important to mention on the top that there are only 2 randomized controlled trials, and only one, the study by Yanez, that is a randomized controlled trial in a population of patients who are immunocompetent. The Peters trial in line 2 was a population of immunodeficiency, and then as you see, a series of prospective and retrospective observational studies. If you look at the non-invasive failure rate, the Yanez study, and we'll go through that one in a little more detail in subsequent slides, showed a 28% failure rate, meaning intubation, in those patients supported with NIV, compared to 60% in those patients supported with standard oxygen therapy. Of note, in line 2, the Peters study, we see the opposite, in fact, that those patients supported with NIV had double the intubation rate than those patients supported with standard care. Seemingly contradictory findings. However, it's important to note that in the immunodeficiency population, and many of the studies and publications available, that there seems to be, and it's hard to state for certainty, but seems to be a trend that those patients who are immunodeficient, supported with non-invasive ventilation, have a delay in intubation. There's a tendency to avoid intubation in this population for deemed higher risk, and thus may be biasing these results against NIV due to the delays in accepting failure. And we'll go through that in more detail. If you look through the observational studies, we see reintubation rates ranging from a low of 19% to a high of 77%. Very diverse findings. We now look at the Vyaire study in more detail. What we see is this is a study of young patients between averaging 16 months of age in the NIV group and 18 months of age in the control group. And these patients are relatively sick with PF ratios less than 200. But it's important to acknowledge in this study that the patients enrolled were largely those with asthma, bronchiolitis, and other viral processes. But this really is a study of young children with viral pneumonia and viral bronchiolitis as a predominant of the subjects studied, with a few patients with bacterial processes. Having said that and acknowledged that, what we see here is a very different intubation rate. The NIV patients had a 28% chance of or rate of intubation, and the control patients with standard oxygen therapy, 60%. Despite the differences in intubation rate, it's noteworthy that there were no differences in length of ventilation for those that were supported with NIV or IMV. No difference in ICU length of stay, and no difference in hospital length of stay. But this study does support the use of NIV for pediatric patients with acute hypoxic respiratory failure. Now move on to the PARTY study by Kamani and colleagues. This was a large international point prevalence study looking at PARDS diagnosis and management worldwide. And we'll now focus of that large study on those patients that were supported with NIV. So for those patients with NIV PARDS, based on the definition previously reviewed, only 17.5% met diagnostic criteria with a blood gas using a PF ratio. Reason I make this point is it's important to stress that the trend that we're seeing across patients with PARDS and NIV PARDS particularly of not managing with an arterial line, and thus these patients were diagnosed with PARDS using the saturation FiO2 ratio. Of the 160 patients with NIV PARDS, 50% were intubated, and of importance, 86% of those intubations occurred within 48 hours of PARDS diagnosis. And we see this as a theme, that those patients who are supported with NIV who are not going to be adequately supported fail relatively quickly. On the other side, those patients that are supported for NIV for a period of time, in this study more than 48 hours, are more likely than not to proceed along to resolution without the need for intubation. Ventilator-free days and length of ventilation among survivors for NIV PARDS who were subsequently intubated approximated those who were initially had moderate to severe IMV PARDS, or invasively ventilated PARDS. So what we see here is that those patients supported with NIV who went on to intubation with a sicker subset, as one would suspect. And the real challenge here is figuring out those sicker patients who may not be best benefited or best supported with the NIV and who are likely to require intubation. Hypoxia, severity of PARDS diagnosis, and NIV are strongly associated with the risk of intubation as well as mortality, which is another way of saying exactly what I just summarized. And overall, for those patients who had NIV PARDS, the mortality rate in the PICU was 25%. So a very sick population. If we look at those data graphed a little differently, these are those, again, 160 patients with NIV PARDS. These patients are now distributed based on hypoxia severity, blue being mild, red being moderate, and green being severe. The vertical axis is cumulative population free from intubation, and the horizontal axis is time in days outward to 3 days. And what we see here graphed differently than the data displayed or described in the prior slide is that those patients with severe PARDS are much more likely to be intubated than those patients with mild or moderate PARDS. And those patients who are intubated early on, generally within about a day, almost always within 2 days, and essentially always within 3 days. We look at these data broken down a little more granularly. What we see in the first column, NIV PARDS, 160 patients. then the 80 who are intubated, and the 80 who are not intubated. And what we see here is that mortality rate of 25% for the NIV PARDS group, compared to only 5% mortality in those patients with NIV PARDS not intubated, and a total mortality rate of 15%. You see that difference where those with NIV PARDS who end up being intubated are more ill, as one would expect, and also 90-day mortality, 28-day ventilator-free day, both IMV only and those who are IMV or NIMV, and the length of support of mechanical support, again, higher in those who are ultimately intubated. Next point here is the importance of the use of the SpO2 FiO2 ratio to predict NIV failure. You don't need an arterial line to predict NIV failure. So these are 3 studies. The first, again, is the PARTY study by Kamani, looking at international use of NIV. The middle group, another study here out of Mydorma Kalunga and bottom Panzadina. These 2 prospective observational study and another retrospective observational look, much smaller studies here than the PARTY study. What we look for in the middle here is the risk factors for NIV failure. And we've already talked about for the PARTY study, the risk factor there of hypoxia as shown on the prior slides. But we see the same thing in these other 2 studies. And I want to point out here, without going through the details of the failure criteria, is the timing of failure. We see here early failures are less than 6 hours, intermediate failure 6 to 24 hours, and late failures were rare and really had no associations with risk factors. So it's early failures is what we're looking at. And same thing here for the last study by Panzadina, that we start seeing failures as early as 2 hours. The take-home message is that if a patient's going to fail NIV, they're going to do so early, and the clinician really needs to take that into consideration and not push the limits of NIV, because pushing the limits of NIV may lead to increased mortality rates. Okay, immunocompromised patients, what we have is a subset of very sick patients. These studies, the first one by Peters, the second by Lindell, and the third one by Rowan, all look at various cutoffs, various predictors for NIV failure. What I want to focus again here is the time frame. And if you look at the Lindell study here in the middle, what we see is increased mortality if you push high flow nasal cannula or NIV use more than 6 hours and the patient fails, mortality increases. Again, a common theme. One study that's worth going through in a little more detail that was not included in the PLEAK 2 recommendations because it's published just this current year. And this is looking at patients who are immunosuppressed PARDS. So the PARDS category here, the 603 patients are immunocompetent patients. The 105 patients, the IPARDS, are immunocompromised patients. If we look at the use of NIV, what we see is a much higher use of NIV in the IPARDS, or the immunocompromised PARDS group, than the immunocompetent PARDS group. Largely, that's related, I believe, my speculation, to those clinicians who are really trying to delay intubation or avoid intubation in the immunocompromised population, especially the BMT population, for fear of an increased mortality rate. If we look at those patients diagnosed with PARDS on NIV, same difference. If we look at those diagnosed with PARDS on NIV who were then intubated, same difference, 70% versus 44%. But if we look down here at the hours after PARDS diagnosis on NIV until intubated, what we see is an average of 5 hours for the immunocompetent population, but a delay out to 14 hours, supporting my speculation in the immunocompromised PARDS group. If you look at the initial PARDS, that progresses to severe PARDS, much worse, much higher risk or incidence of worsening PARDS in the immunocompromised group. So with that, how do you summarize this, and how did PAARC summarize all the available data? What they conclude in their recommendation is that in patients on NIV who do not show clinical improvement inside of the first 6 hours of treatment, or have signs and symptoms of worsening disease, including increased respiratory or heart rate, increased work of breathing, and worsening gas exchange, they suggest that intubation be used in comparison to continuing non-invasive ventilation. Acknowledging that this is based on low certainty of evidence, but of those experts, 94% agreed. So the take-home message is, if you are going to try NIV for those with PARDS, immunocompromised or immunocompetent, failure to improve within 6 hours should lead to invasive mechanical ventilation. And to stress that point, that the recommendation includes those patients with immunodeficiency with higher risks of invasive mechanical ventilation. And if anything, they suggest that intubation be used earlier in comparison to NIV in those patients with severe NIV PARDS or other severe organ dysfunction. So intubate within 6 hours, may be sooner in those patients who are showing signs of severe disease or multiple organ dysfunction. I'm not going to go through this in detail because of time limitations, but this is a great summary of the evidence looking at the use of NIV and high-flow nasal cannula in resource-limited settings. And I will summarize that data through PAARC 2, through their recommendation that in resource-limited settings, they suggest that the use of CPAP or high-flow nasal cannula over standard oxygen therapy be done in patients at risk for PARDS. Again, consistent theme of very low certainty of evidence with a 92% agreement. They do remark that the use of CPAP should be conducted under physician oversight. Additional recommendation is that they suggest the use of CPAP over high-flow nasal cannula in resource-limited settings in those patients with possible PARDS. Again, very low certainty of evidence, and a decrease in agreement of this statement to 83%. So the conclusions from PAARC 2 on non-invasive ventilation is that non-invasive ventilation may be beneficial in reducing the need for tracheal intubation in a subset of patients with PARDS. However, the certainty of evidence support this practice is very low, and NIV use may expose some children to potentially increased risk, especially if there's a delay in intubation. Trials of non-invasive ventilation should therefore be time-limited, with close monitoring for worsening disease and NIV failure. The role of high-flow nasal cannula in the management of patients at risk or with possible PARDS remains to be studied. And if we take that into and look at the high-flow nasal cannula recommendation from PAARC 2, we cannot make a recommendation on when to use high-flow nasal cannula in patients at risk of or with possible PARDS. Further studies are needed to identify clinical indications for high-flow nasal cannula in patients at risk or with possible PARDS. So PAARC 2 did not make any recommendations on the use of high-flow nasal cannula, citing the lack of any usable definitive data. This is a research statement encouraging the field to research high-flow nasal cannula in those patients at risk for PARDS, with possible PARDS, and those who do in fact have pediatric ARDS. I do want to share one study though for high-flow nasal cannula, comparing it to non-invasive ventilation. In this study, which looked at those patients receiving either high-flow nasal cannula that converted to NIV in the first column, high-flow nasal cannula never converting to NIV, and the third column, those patients that only received non-invasive positive pressure ventilation. What we do see here is a lower intubation rate with high-flow nasal cannula, a lower mortality, and a shorter length of stay. Of course, I'm going to state the obvious, and the limitation of this study is that this study does not fully correct for severity of injury, severity of lung injury, or overall severity of medical condition, looking at multi-organ system effects. So with this, the data here supports high flow nasal cannula. However, the PLEAK-2 group view that the limitations of this study precluded any definitive recommendation. But I do show this in the sake of being complete in my presentation and literature search. So is a trial of high flow nasal cannula indicated for those patients with PARDS? And the answer is we don't know. There's no generally accepted escalation and de-escalation algorithm. In some centers, it almost seems like it's high flow nasal cannula for everyone, especially to facilitate extubation. Again, no data to support that approach. And one of the concerns is the associated expense and inconvenience for families on both sides. The inconvenience and the expense might be in an unnecessary ICU stay or an increased ICU and hospital length of stay by employing high flow nasal cannula without a clear protocol, without clear indication, and without standardized weaning. And on the higher end, the risk end of this, it may have minimized or may potentially delay intubation if and when indicated. So with that, I'm going to leave pediatric ARDS and move forward here into asthma, and then a little bit on post-extubation respiratory distress and intra-hospital transports. Studied by Bessette in pediatric critical care, an old study now from a decade ago, looked at non-invasive ventilation in a series of pediatric patients with status asthmaticus. And what we see is significant improvements very quickly in the study group, the NIV group, in terms of a reduction in respiratory rate on the left and heart rate on the right. Important to note here that these improvements occurred within 2 hours in both respiratory rate and heart rate. If you look at the mean clinical asthma score, a composite of the patient's overall severity of illness related to their asthma, what we see the same findings is a very rapid improvement within 2 hours in those patients supported with NIV. A very recent study publication from the Annals of the American Thoracic Society just came out, looks at trends in asthma management over a decade from 2012 through 2021. In light blue on the top, these are patients managed with standard oxygen therapy or room air. The use of just standard oxygen therapy has decreased dramatically. Despite the lack of definitive data, the use of high flow nasal cannula has increased quite exponentially here. But also increased is the use of non-invasive ventilation in navy blue, as well as the use of CPAP in purple. Of note, through these years, the incidence of invasive mechanical ventilation here in orange has slightly decreased. Part of this is the scale of the slide, but there is a downward trend except for this peak here in 2020, presumably related to COVID. So what factors influence respiratory device use in pediatric asthma, coming from the same recent publication from Rogerson? What we see here is admission year. Clear trend over these years towards high flow nasal cannula, CPAP, and non-invasive ventilation, with a slight decline in invasive mechanical support. Age, older patients are more likely to be managed with CPAP and BiPAP. Younger patients more likely with high flow nasal cannula. Male sex more likely to be intubated. And PRISM score as a marker of severity of illness, what we see here is that all patients with the increased severity of illness are more likely to be supported with mechanical support. Not a surprise, and also not surprising, is the highest risk or the highest incidence of support is with intubation in the sickest of patients. Definitive data, though, are lacking in terms of the outcomes when comparing these various approaches. All right, moving on to an adult-based study for NIV use after extubation failure or respiratory distress after extubation. I need to show the adult study because there's very limited data despite common use in pediatrics. If you look at the NIV group, 48% reintubation rate, and the standard group, 48% intubation rate. So no difference here. It didn't look like NIV in this group prevented reintubation. But what's really important to stress here, going back to the timing of accepting failure, a mortality rate of 25% in the NIV group and 14% in the standard oxygen group. This does not mean that NIV caused harm, because if you look at the time to reintubation, 12 hours with NIV, only 2.5 hours of standard therapy in the standard therapy group. So what we see here is that we should not be delaying intubation for those patients who fail NIV. And in fact, NIV may have a very beneficial role if used appropriately, if used in the right population, and if failure is accepted in a timely fashion for those patients in whom NIV is not optimal. Interhospital transports, an area getting more and more attention. This study at Achima in Peds Critical Care in 2019 looked at the need for patients who are transported between hospitals on CPAP or BiPAP, for the need for active bag mask ventilation, CPR, or the occurrence of apnea, desaturation, bradycardia, hypotension, or air leak. And what we see as a summary on the bottom is extremely low incidences of all of these occurrences. So it appears that inter-hospital transport of patients on non-invasive ventilation, CPAP or BiPAP, is in fact a reasonable approach. And their conclusion is that the results suggest that NIV during critical care transport of children may be safe, but the effectiveness of NIV during transport cannot be commented on due to the lack of reported evidence. So it appears safe, does not appear to have many downsides, but again, we need definitive outcome data to make a more definitive statement. With that, I'm now going to move on here in the last 10 minutes or so to look at outcome predictors, challenges, risks, and benefits. So pediatric non-invasive respiratory support, I'm not sure the composition of those attending today, but if you are a group of respiratory therapists, what you'll see, and so what you know is that non-invasive respiratory support often requires more time and more effort than a patient who is intubated and sedated. So is it worth the effort? The answer here is we're still trying to generate the data, but it appears to be. First statement, pediatric inpatient non-invasive respiratory support has increased exponentially despite the lack of convincing data. It is being used more and more, both high-flow nasal cannula as well as NIV, CPAP, and BiPAP, without any more convincing data than I've shared. So why? Same reasons for adults. We do have supportive data in adults in the neonatal NICU world. Often we're trying to avoid intubation and its associated complications. On the other end of the spectrum, we're often trying to facilitate extubation to decrease length of ventilation and to promote patient and family satisfaction, because no one wants themselves or their loved ones to be sedated and intubated on an invasive ventilator, and would much more rather have these patients awake and interactive on a non-invasive approach for respiratory support. So what are some of the predictors of NIV failure? And we talked about time limits earlier, but what else can tell you that this patient may be more likely to fail CPAP or BiPAP? One is actually the FiO2 at the start of non-invasive ventilation. And this comes out of work from Baker just past year, that those patients who have an FiO2 greater than 45% at NIV start are more likely to fail. Those patients who have worsening tachypnea at 1 hour and especially at 6 hours are more likely to fail. Looked at it in terms of hazard ratio, what we see at 1 hour of non-invasive and 6 hours of non-invasive ventilation, that if the respiratory rate is increasing at 1 hour, there's a 3.5 times increased risk of intubation, and at 6 hours, it goes to a 5.6 time risk. If the FiO2 is greater than 45% at initiation, at 1 hour, the patient has a threefold increased risk of intubation compared to those patients who start off with an FiO2 less than 45%. And that increases if you push it out to 6 hours. The PLOD score is a marker of overall organ dysfunction. What we see here is expected again is those patients with a higher PLOD score are more likely to fail NIV, correlated to those more ill patients. So the risk factors associated with increased length of mechanical ventilation invasively are the use of non-invasive ventilation as well as continuous sedation on the first day of invasive ventilation. So we look at this differently. This now takes the prior slide and looks at those patients who are now intubated and goes back and says that those patients who are intubated, who had a trial of NIV, were more likely to have an increased length of total ventilation. That doesn't necessarily say that the attempt of non-invasive ventilation is bad, because what this study does not consider is all those patients supported with NIV who are never intubated. So what we need here, and what we really are striving to gain, but we don't have, is that crystal ball to figure out which of these patients who have some various component of PARDS, at risk for PARDS, possible PARDS, are going to worsen and require invasive ventilation. If you knew that, if you had a predictive score or predictive algorithm, those patients who are going to go on to be intubated anyway should be intubated up front. And those patients who you knew were never going to be intubated would be supported successfully with NIV. The problem is we don't have that magic crystal ball. We don't have that definitive scoring system, and we're left to clinical assessment. Having said that, this is the same situation, the same data now in an immunosuppressed population, and we see that those patients who had NIV prior to invasive mechanical ventilation with intubation, or those patients who are non-survivors, were more likely to have NIV before their time of intubation than survivors who were outright intubated. Again, doesn't look at those patients who went to NIV and never got intubated. Modes and outcomes. I know probably some of you want to hear a long talk on modes and outcomes. I do similar presentations with invasive ventilation, and with invasive ventilation, I make the same exact statement, is that no mode of NIV or invasive mechanical ventilation has ever been shown to improve true outcomes in pediatric patients. So when it comes to modes, one can argue for a various type of mode because it may be more comfortable for a patient, or it may be a clinician or institution preference. But if you look at definitive outcomes, mode has never shown to make a difference. The key is knowing how to use the modes, knowing how to use the modes appropriately and optimally, and for each of your individual units to have an approach, a standard approach. So all of your patients with asthma, all of your patients with ARDS are managed similarly, and it's not mode du jour. Some good practice statements in terms of team and environment. NIV should be delivered in a statement with trained, experienced staff who closely monitor for rapid deterioration of a patient if that were to occur. Pretty straightforward, good practice statement with 96% agreement. When delivering NIV, the provider should choose the interface that provides the most efficient patient-ventilator synchrony for the child. All agreed. Patients receiving NIV should be closely monitored for potential problems, including skin breakdown, gastric distension, barotrauma, and conjunctivitis. 98% agreement. 96% of the experts agree that heated humidification should be used for NIV and high-flow nasal cannula. And lastly, as a good practice statement, for patients with poor tolerance to NIV, sedation can be used to improve tolerance with 92% agreement. Challenges in pediatrics. We all know this. We have a huge variability in our patient size and age. We have to find approaches that work for neonates all the way up through young adults. We have patients well less than 3 kilos to patients who are over 100 kilos. We have a large variety of diagnoses: medical, surgical, acute, chronic. We also have to consider neuromuscular weakness and congenital heart disease and their nuances. Technical challenges to NIV. The inspiratory flow rates ideally should be adjustable based on our patient's inspiratory demands. Excessively high inspiratory flow rates may lead to patient discomfort, could lead to dried secretions with the potential for airway obstruction, and really again stress the need for active humidification as previously mentioned. Our NIV technology for bilevel support must be fast. We must be able to have these devices reliably synchronized with the patient, especially for our small infants who may become quite tachypnic. Interfaces, despite a lot of really excellent work by our device companies, remain probably the biggest challenge. We need to optimize these interfaces to get the best possible patient comfort. And we have to be sure that the interfaces used maintain skin integrity and protect the patient's eyes. Keeping in mind in our neonatal and infant population, we of course don't have much room to work between the nose and the eyes. Should patients be managed with nasal masks, oral nasal masks, full face masks, or helmets? Really varies based on individual clinician and institutional preference, available technology, and individual patient needs. I put this up for two publications, one from a decade ago and one very recently this year, looking at different approaches to develop custom-made, perfectly fit masks for our patients who require longer term, and leave longer term as vague, to chronic non-invasive ventilation. Probably not applicable for these patients who are on non-invasive support for a short period of time. But there's hope out there for our long-term NIV patients. So in conclusion, pediatric non-invasive respiratory strategies, what are some of the benefits? We can avoid, in some cases, and often shorten the duration of invasive ventilation and associated complications related to pharmacologic sedation, airway injury, lung injury, nosocomial infections. We could shorten and sometimes even avoid an ICU length of stay, and we could potentially improve patient comfort and patient family satisfaction in terms of oral feeding, ambulation, talking, and interacting. Some of the risks remain skin breakdown, patient discomfort if the mask is not appropriately fit, risk of aspiration, especially for full face masks, potentially prolonged ICU stays in those patients who have delayed weaning. And I would stress the need for weaning protocols for both high flow nasal cannula as well as NIV. And it's important to again stress that delayed intubation has been associated with worse outcomes. NIV training and experience of the clinical team really are important to determine the success with non-invasive respiratory support. Contraindications to non-invasive respiratory strategies: general cardiac or respiratory arrest, non-respiratory organ failure, including encephalopathy, severe GI bleeding, and hemodynamic instability, facial surgery or trauma, upper airway obstruction, the inability to protect the airway, thus increasing the risk for aspiration, and similarly, the inability to clear secretions. So my opinions, and these are just those in conclusion here, a trial of non-invasive respiratory support is generally reasonable in situations of acute hypoxic respiratory failure to avoid intubation or facilitate extubation. However, one must be very cautious in those patients with severe hypoxemia. And if it's clear that the patient's severe hypoxemia is going to progress, is not reversible in a timely fashion, those patients, intubation does seem very reasonable and might be the best approach for the individual patient to reduce risk. One must accept failure early, per PLEEK 2 within 6 hours and often within 1 to 2 hours if a patient is not improving, and transition to a higher level of support when indicated. Never delay intubation if non-invasive respiratory support does not yield clear and timely benefit. The trial of NIV after failing high-flow nasal cannula is still debated. PLEAK 2 does say or suggests that it is a reasonable approach, but that really, to me, comes down to the trajectory of illness and your general sense of the likelihood of eventual intubation. And lastly, stating the obvious, close monitoring is always essential for all of our patients. So if we summarize the data now, not just my opinions, the application of non-invasive respiratory support should be based on pathophysiology while taking severity of hypoxemia and trajectory of illness into account. Clinical improvement should be seen within 2 to 6 hours of optimizing settings, if not escalate, including intubation. The clinical need for pediatric-friendly technology continues to grow. The interfaces seem to remain the largest challenge currently. And to stress those who are in the world of research, please research these concepts as we need more definitive data. And lastly, I'll come back to the exact same case I started with. I'm not going to reread the slide and leave you with the same question. High-flow nasal cannula, NIV, or intubation? Not sure if this talk reinforced or reaffirmed what your initial answer was, or whether it changed your mind. And the goal here, again, was not to promote any one approach. It really was to try to provide you with the objective limited data that we have and share with you the PLEAK 2 recommendations, which are a large cohort of experts around the world, and to hopefully base most of my comments on definitive data. So with that, I'm going to conclude and lead you with something we can't debate, that the ultimate goal is a happy, satisfied patient. So with that, thank you again for joining today, for your participation. And in the last 10 minutes or so, I'll be happy to answer any questions you may have. And if anyone wants to reach out to me, my email addresses are on the slide. So thanks again, and I'll turn this back over to Beth.
All right, thank you for your time today and presenting such a great presentation. If there are any questions, please make sure that you enter them in the Q&A, and I will go through and ask any questions that are posted. We'll give it just a minute. I think you did such a great job going through and explaining everything. Not sure if they're going to be.
And I know questions are so hard through the Zoom format. I so much prefer in person, and especially Zoom if we could have folks talk and interact, but I know this is set up as a webinar, so we'll wait to see if anyone types.
Yeah. But great content. For this presentation, it will be recorded and part of our replay. So not a question, but wanted to give you thanks for your presentation today from one of the attendees.
Oh, okay. I just saw that. Oh, Doug. Hey, Doug. Hope you're doing well. Thanks for joining.
So like you said, we did have people attend from across the US, across the globe. If there were part of the presentation that you missed, it will be available on a replay on the InvaVox platform at a later date. So, you know, sometime next week, if you have a colleague that says, hey, I really hate that I did not get to attend that webinar, they can go back and join the replay. All right, so no questions. So at this time, we are going to end the presentation. Again, thank you so much for your time today and presenting on the NIV strategies for our pediatric patients, which is such an important population and also often a difficult population to treat. So we really do appreciate your time today. Thank you.
Great. Thanks, everyone. Please reach out if I can help.
All right. Thanks. Bye-bye.